Good morning. My name is Kenneth C. I'm one of the second-year residents. The title of my presentation is Masquerade Balls, and my faculty discussant, Dr. Dubovy, we have no disclosures. My case begins with a 54-year-old Asian male presenting to Bascom with painless vision loss in one eye for a couple of days. He's had 2 prior episodes in the past that have spontaneously resolved. His past medical history is withheld at this time. In the right eye, his vision is 20/20. In the left, count fingers at 1. Pressure and pupils are unremarkable, no APD. The anterior segment exam of the right eye is unremarkable as well. And then in the left, it is notable for a white and quiet eye with diffuse KP and 1 to 2 cell in the anterior chamber. Could I get a resident to describe the photos that they see here?
How about Dr. Dewar? We have fundus photos of the right and left eye here. On the right eye, we have a clear view in. The disc looks normal. Vessels, macula, and periphery look grossly normal to me as well. Left eye, not so normal. The view is a little bit blurry from, seems to be some Vitreoretinal. There's some haze coming off the disc and difficult to visualize a lot of the vessels, maybe a little bit of attenuation on that superior arcade. In the periphery, a lot of exudation and hemorrhages within the retina.
Nice. So view is obscured from a dense Vitreoretinal. You have diffuse retinal and vitreous hemorrhages. At the time of examination, it was also noted that the patient might have a retinal detachment, a low-lying retinal detachment. So for workup, more imaging and history was obtained at this time. A complete review of systems was mostly negative except for a couple pet cats at home. And fundus autofluorescence in the right eye is grossly normal with the left eye. A little bit of a blurry view with some spotty hyper and hypoautofluorescence. The FA in the right eye was grossly normal with the blurry view in the left eye as well. And ICG sort of the same, right eye normal, left eye hazy view. B-scan was notable for some vitritis here. And you can see a serous retinal detachment, and at the time, no breaks were noted on B-scan and a little bit of retinal thickening in the posterior pole. What would be your differential at this point, Dr. Dewar?
I'm suspicious that your withheld medical history is pretty important here. But if the patient has like a history of HIV or something, might be concerned about a viral process, ARN or porn. If it's like an IV drug user or somebody who has like other catheters, you could be considering like a endogenous endophthalmitis. Any history of cancers or like lymphomas, leukemias, you could have intraocular tumors. Other inflammatory conditions can cause this, maybe like VKH or sarcoid.
Nice. That's a pretty good differential. We are thinking along the same lines here. So top on our differential was a possible infectious process, endophthalmitis, ARN, viral, toxo. Also inflammatory processes like sarcoid or VKH. Of course, you can't rule out the neoplastic malignancies or other masqueraders. What would you do next? How about some labs? Sounds good. So we got some labs there. Quant, Toxo, FTA, ACE, and viral panel were all negative. So we're revisiting our differential here. Less likely an infectious process at this point. Sarcoid, the ACE was negative. No history of ocular trauma in the other eye. The imaging not consistent with VKH, so we're thinking maybe this could be a Masquerade syndrome. Diving into Masquerade syndromes, during my history, the etymology of the word masquerade is from the Italian word mascara, which in English means mask. It was popularized in the 15th to 16th century by the French and Italian royalty. And since then, it's really decreased in popularity, but the most famous modern day event is the Carnival of Venice, which is still ongoing. When looking at Dr. Google, the word Masquerade syndrome actually refers almost exclusively to ophthalmic diseases. I didn't know this, but looking even closer, most of them are referring to uveitic conditions. And most interestingly, the original use of the term Masquerade syndrome originated from a 1967 report of a conjunctival carcinoma masquerading as a chronic conjunctivitis. So the great masqueraders of medicine are very similar to that of the great masqueraders of ophthalmology: lymphoma, lupus, sarcoid, amyloid, syphilis, TB, Lyme. But I would be remiss not to mention the great masqueraders here at Bascom Palmer, and would like to begin with this charismatic 70s dance enthusiast who likes to masquerade as an ophthalmology resident during the week. And how about these ophthalmology residents who masquerade as retired bingo aficionados, or these fake resident athletes masquerading as real resident athletes, and these 7 individuals roaming the halls of Bascom Palmer masquerading as ophthalmologists. So to recap what we have here: individual with unilateral vision loss and a white and quiet eye, painless, and lots of vitritis with clumps of cell, or I might call them masquerade balls, and a negative lab workup. So in the words of our wise senior residents, we can choose either choice A, you're doing great; choice B, need some beams; choice C, keep logging; or choice D, gotta get in there. So of course the decision was made to get in there, and a diagnostic and therapeutic vitrectomy was performed. Here you can see Dr. Albini and Dr. Kim Tran performing this standard vitrectomy. Here you can see them entering the eye with quite a bit of vitreous here, and as they clear the vitritis out of the way, underneath you see a really large peripapillary creamy exudative lesion with quite a few peripheral retinal hemorrhages, a lot of whitening. Here you can see them inspecting the eye at the very end. And no other procedure performed besides a standard vitrectomy here. The vitreous biopsy was notable for, well, a negative micro. The flow cytometry demonstrated a positive CD19 and 20 and lambda light chain restriction, which is consistent with a monoclonality of B cells. If I could have one of the residents describe to me, actually Dr. Dewar, describe to me what you see here on the path slide.
I got some large blue cells here, probably lymphocytes,
All right,
and they have some abnormal, prominent nucleoli in many, if not most of them. That's all I have for you.
And how about here? Not too difficult.
CD20 positive.
Nice. All right. At this time, I'd like to see if Dr. Dubovy would like to chime in about any comments on the path here.
If you go back, I mean, the first thing what's interesting about this is the number of cells. When we normally get a biopsy for vitreous sample, when you're possibly worried about lymphoma, we usually get about like 3 or 4 cells, and there's sheets of these cells, and you can see that there's a lot of pleomorphism. These cells are large. It's like this cell over here is very large. These cells are large. You see you have some prominent nucleoli. You have an increased nuclear cytoplasmic ratio, and kind of a granular nucleoplasm, and all of this is consistent with lymphoma. When we get these biopsies, it's usually lymphoma versus just some type of chronic inflammation, and sometimes you'll see histiocytes as well. And so, what you see here is, again, this pleomorphism. So what we usually do is we'll get a CD3 and a CD20 because the vast majority of lymphomas in the eye are B cell lymphomas. So we'll do, like, if you go to the next slide, you'll see that the CD20, which stands for B cells, are basically all positive. There are probably some T cells that are present here, but the presence of large B cells that are atypical is consistent with the lymphoma. These are large atypical cells, so it was consistent with a large B cell lymphoma, and you'll get to other things late as we go on, but this is at least a large B cell lymphoma. Whether it's primary or secondary becomes, is another question. And you should also be aware that sometimes you have large atypical cells, and then there's a reactive component to this where you have T cells there as well. And this is kind of like a T cell rich large B cell lymphoma where the inflammation is secondary to. So you got to be careful not to worry, not to lose the atypical cells amongst the background of the normal cells. But you're absolutely right, basically.
Thank you. So, as Dr. Dewar alluded to, the prior history that was withheld after his remote episodes of vitreous hemorrhage, he had actually a mild accident to the arm, after which he developed an upper extremity DVT, which is pretty uncommon for a 50-year-old healthy guy. He had a surgical thrombolectomy during which they saw an atypical looking lymph node. They took it and found that there was B-cell lymphoma in that lymph node. So the final diagnosis is vitreoretinal lymphoma in the setting of systemic diffuse large B-cell lymphoma. And when we talk about vitreoretinal lymphoma or intraocular lymphoma, we have to differentiate between primary and secondary. Primary intraocular lymphoma is typically found in the vitreous and the retina and is associated with central nervous system about 50 to 80% of the time, whereas secondary is usually found in the choroid as in a form of metastasis from a systemic association. Rarely, secondary lymphomas can be found as vitreoretinal lymphomas, and in the literature is quoted to be about 5 to 28% of the time. So distinguishing between primary and secondary vitreoretinal lymphoma is super important because the primary vitreoretinal lymphoma may cause you to focus on the CNS and perhaps miss a systemic manifestation of a bigger disease. And here, secondary vitreoretinal lymphoma, you can see in the literature, has masqueraded as many things in the past, including a retinitis and vasculitis here, masquerading as ARN. And actually, this case published by one of our fellows, Dr. Echegare here, as a bilateral panuveitis. So for diagnosis of vitreoretinal lymphoma, as Dr. Dubovy said already, histology is required. And the prognosis is typically grim. For primary, survival is about 31 months. And for secondary, based on the review of the 4-case series, I looked at 14 to 62 months. So the question is this a secondary vitreoretinal lymphoma? The ocular symptoms preceded the lymph node diagnosis, which moves us to think maybe this is primary. However, it was associated with a systemic lymphoma. On the other hand, vitreoretinal infiltration was present without any choroidal involvement, and follow-up pan testing did not reveal any further findings on MRI, PET scan, etc. And so the answer is we actually don't know. So for the treatment of vitreoretinal lymphoma, there's no universally accepted standard of care, but typically it's a combination of systemic and local therapy. For primary intraocular lymphoma, you have to consider whole brain radiation, and for very severe conditions, you have to consider stem cell transplant. So our case, he chose R-CHOP chemotherapy, as well as 1 dose of an intrathecal methotrexate and multiple intravitreal injections. On post-op month 1, we have a beautiful photo montage here of how he was doing. However, his vision was still count fingers. OCT shows a flat retina. Post-op month 5, an Optos photo shows improvement of the hard exudates in the retina. However, the FA demonstrates some RPE and retinal changes peripherally especially. The vision, however, has improved to 2200. This is back in November. So looking briefly at future directions, I think that the most interesting thing I found is this test of mid-88 gene mutation in PCR. And this phase 1 clinical trial most notably looked at the aqueous humor detection, which the sensitivity is a little bit low at 67%, but it is only phase 1. But the thought of being able to diagnose it from an AC tap is actually pretty intriguing. Of course, there are always newer drugs on the horizon, such as bortezomib, pomalidomide, which respectively increased overall survival and progression-free survival in refractory large B-cell lymphoma.